a couple of things. In 10 days, it's the 31st. So make sure that you're on top of getting all your stuff in for clinical paperwork wise, have appointments set, my clinical exchange account set up, all of that. So just be mindful. Monday's lecture is recorded. You guys are all rock stars because you've been so patient with me with grading. I'm teaching 2 classes, and then all this clinical director stuff has been crazy. So next week, IS lecture may be recorded on Wednesday, depending on how much of your guys' paperwork I start to get through, because I'm going to start entering you next week on my clinical exchange if your hospital requires that. So depending on how far I get with that, we may or may not have live lecture on Wednesday.
For the stuff we've entered and turned in through the Blackboard, if we've gotten a grade for it, we're good. It's submitted and done. Okay.
So if you have a check mark next to it, it's good.
Cool.
I've been trying to keep up on emails when I look at it and I notice something. Immunizations, remember, if they're over 10 years old, you have to have a titer pulled to prove that you're immune to it, and send that to me. So the hospitals want us to prove to them that you have immunity to all of those diseases. So there's that.
And then
Next,
real quick.
Yeah.
I know I have to get another TB for children's, and I just recently did one. Can I get that like right before clinicals? Is there a cutoff date for that one?
I would get it in a couple weeks because your badge pickup day is June 26th, and I want to make sure they have enough time to go over the paperwork. Good question. Let's look at something else. I haven't been able to come up with an order and charting activity or example yet. It is on my list. If it doesn't get done by next week, that's something we do go over in the lab as well, especially with their airway clearance therapy lab. So next week's our last week of online only. And then after Memorial Day, we get to go back in the lab. Yay. So we can get hands-on.
Reading through our disease book at the end of it, there was actually I think it was in the CF or bronchiectasis, there was a soap before and after in the case study in the very back of the chapter. So that was like, oh, we just talked about
helpful?
that. Cool.
Good.
Yeah.
Okay.
Yeah, saying just the pre and post after therapy stuff.
And I think all the diseases, when they do a case study, have that in that book. So you have an example. Okay, so let's talk about trach and suctioning. So when you hear tracheostomy, trach care, airway care, suctioning, what comes to mind? What are your guys' initial thoughts?
People using pens.
People using pens.
Make airways in movies. That's what comes to my brain. Yeah.
It's very dramatic. You can see it. It does happen in the ED. You can do it on the side of the road if you need to. But it's very dramatic in the movie.
Yeah, bypassing the upper airway is the professional way to say that.
What else do you guys think?
All the mucus horror stories is what I'm used to.
Mucus horror stories. Yes, you'll have your own stories to tell. Anybody afraid of doing trach care? I see yeses and nos.
As long as I don't have to install it, I can take care of it. And
I think I'm okay. I'm better with a trach than doing poop.
Yes. So
it's RT and not RN.
Exactly. I was terrified as a student for trach care because that's someone's breathing, that's their airway. And if they lose it, it becomes an emergent situation. But now as a practitioner, it was one of my favorite things to do because you're helping that patient feel so much better. You're cleaning them up, you're making them look nice for their family, you're getting rid of their secretions so that they can breathe better. And know, especially as a student, you'll have your preceptor there to help you and ask for help. If you need extra hands, they'll help you. If you're out in the field and you're a practitioner, you can ask one of your other RT buddies to come help you with the trach, especially if it's like an emergency or a difficult airway, they'll come help you so you don't lose that airway.
Stacy, Jade said she's having difficulties getting with her Zoom, so she just wanted me to let you know.
Thank you. I had difficulties yesterday and today. So before we start, I did just post an optional assignment that'll be 5 bonus points. And we'll get to the video in the slide, but if you watch that video after lecture and send me 2 questions that I'll respond to, you'll get 5 bonus points. It's completely optional, but my video hasn't been working on Zoom and it kicked me out this morning like twice. So that is why we're not watching videos today.
I like bonus points.
All right. Okay, so trachs and suctioning. There we go.
Such a cool picture. I looked at it. That
Google
open
Slides.
trach.
Oh, this, okay. So know the difference between tracheostomy and tracheotomy. So tracheostomy is the opening of the airway in the neck. So it's the opening in the neck. Tracheotomy is the procedure to establish the tracheostomy. So tracheostomy is the hole. Think of stoma. It's in the word tracheostomy, stoma. Tracheotomy is the procedure. Okay, so the tracheostomy is going to be performed via tracheotomy. And there's 2 different types of procedures. So you can have the procedure in the OR or the bedside. So in the OR, you're going to have the picture on the left, and you can see that they cut a line through the neck here, through the tissue, and then they pull back the skin, and then cut between the tracheal rings, and then place the trach. And then they use these sutures here to suture it closed, and they'll suture the flange, which is that big oval piece to the neck, and let it heal that way. The second procedure is through a percutaneous trach. So we can establish in the OR via surgery, or percutaneous, which is typically done at the bedside. And this uses a long dilator, and it starts, this picture is not a very good picture, but it's narrower at the pointy end. And then as they push this dilator through, it'll cause the opening in the neck to get bigger. So it dilates it until it's the size of the practitioner's choice. So critical care doctors, pulmonologists can do this, trauma surgeons have done it, ENT, anesthesia. So attending critical care physicians will place the percutaneous trach. And what's really cool about this is we get to be a part of that. So we assist with bedside percutaneous trachs, and it's so cool to watch. And then as they put the dilator in, you can see this little white piece here. Get my little laser pointer thing. This little white guy here is going to hold the opening. So once they establish it to the size that they want, they'll take this off, the dilator, and then they'll leave the white placeholder in, the airway holder, and they'll slide the trach tube itself over that so that they know it's going to guide it into the proper position. So it's really cool. And those are not usually sutured into the neck. So then we'd put the trach tie on and secure the airway that way. The incisions, if we are doing an OR trach, the incision is going to be between the 2nd and 3rd tracheal ring. 2nd and 3rd tracheal ring.
Hey, Stacy,
Yeah.
how are they, this may be a stupid question, but how are they breathing during this procedure?
So that is a great question. So they're going to be on mechanical ventilation.
Okay, gotcha.
Great question. So in the OR, they're going to be sedated, paralyzed, and intubated, and it's a more of a controlled environment. And then percutaneous trachs are going to be done in the ICU at the bedside. and they're already going to be intubated. So we will take a bronchoscope and we will go through the upper airway, and that camera will allow us to see if we're in the right position with the dilator. We just have to be careful that the surgeon doesn't accidentally poke our bronch with a scalpel, because then we have to send it out for repair and it's very expensive. So percutaneous trachs, an absolute indication for it would be need for an emergent airway. So if you have a patient who's mechanically ventilated and they're intubated and something happens with the endotracheal tube, or if they come into the ED and they have a ton of upper airway trauma, we can place that percutaneous trach quick.
Hey, Stacy. Did you say it was between the 2nd and 7th?
Second and third intercostal tracheal ring. Okay, so some relative contraindications for a percutaneous trach would be less than 12 years old. If they have poor landmarks, so you can see in this picture here, they've marked where they felt the landmarks. So the thyroid cartilage, they mark that off. Here is the notch, so they don't want to go below the notch here, and they want to make sure they're below all the cartilage here.
So someone with a lot of adipose tissue and things like that would be a contraindication.
Yep, if they can't
for that,
get a good landmark. So, and even anatomy. So if they just have like a really short neck and they're not sure that they are going to get it in the proper place, they would take them to the OR. Yeah. If they're on a PEEP greater than 15 centimeters of water pressure, that's relative because yes, we risk losing that PEEP and losing the volume in their lungs. But if they were requiring that much PEEP, they may not be stable enough to go to the OR. So then if they're not stable enough for transport, we don't want something to happen on the way back to the OR. If there's an infection, if they have a burn on the area, if there's a growth over the tracheal site, and then if they have poor coagulopathy labs. So if they're not clotting. So remember, the OR is going to be a more controlled environment. Percutaneous is going to be less controlled. It's not as clean. So we can create a sterile field around the site, whereas in the OR, it's a totally sterile environment. Personally, if you guys are ever my RT, please give me a percutaneous trach if I need one. They heal faster. These can leave some pretty gnarly scars. So I would prefer a percutaneous trach.
is there any difference in the quality of the airway between the two? So your OR, you're going to have bigger bore trachs or anything like that?
I wouldn't say quality. I would say specialty trachs are going to more likely go to the OR.
Okay.
Good question. So here is the video. The link's in the PowerPoint. Go back and watch it. Send me questions. So the lady that's going to be standing here, she's going to be your RT. This is your bronch cart. And you can see here, I don't know what frame this is, but you can see the trach tube through the airway and the trachea. And then our ventilators back here. Okay, so some indications. So always know your indications. So upper airway obstruction. This can be caused by trauma. This can be congenital defects, any sort of obstruction. Upper airway trauma. Poor airway protection. So if they are constantly, you have it do a swallow evaluation on them or a swallow test, and that shows that they are continually aspirating their food. or even their saliva or
Just
their
be
upper
like
airway.
neuromuscular
Yep, neuromuscular.
patients.
Sometimes as patients get older, they start aspirating just because their body is starting to wear out. Their muscles don't work like they used to. I had one student tell me when we were doing ACLS that she had a little old lady come in through the ED and they bronched her, and apparently she'd been aspirating her food for weeks and they didn't catch it. They found whole kernels of corn in her lungs. So poor airway protection, and then long-term mechanical ventilation. So the longer that they're on the vent, the more likely they're going to need a trach. And we're going to talk about what happens if people are intubated too long and the effects. Okay, so tracheostomies can reduce or totally eliminate vocal cord injury. So when we are intubated with an endotracheal tube, we visualize the tube going through the cords. So those, let's see, I have a pencil. So if this is our airway and this is our endotracheal tube and our cords are on either side, it's going to keep rubbing against our cords. And that's going to cause damage. So the longer they're intubated, the more cord damage we can cause. Now, because we're going below the thyroid cartilage with a trach, we're going below the vocal cords. So we're not going to be rubbing against them, possibly causing polyps or granulomas on the vocal cords. They'll be able to speak with a speaking valve after they've weaned from the ventilator. It also increases patient comfort, even though they have something coming out of their throat, helping them breathe. Patients can now mouth words to you, and I promise you will become very good lip readers. My best friend and I were both RTs, and we were playing, I cannot remember the name of the game, but we were playing the one where you put like headphones on while you listen to music, and you have to try and read a card out loud, and the other person has to guess what you're saying. Well, we kept winning against our families, and they're like, what? How do you keep winning? Well, we have trach patients, so we've learned how to read lips very well.
Kind of a little off topic, but
You're good.
how common is it for ASL to be used on some of these long-term trach people, like sign language or
Sign language,
alternate?
writing, absolutely, a lot of writing. You'll have family with long-term trach patients who can maybe read their lips or facial expressions that can help you out too. So you will find so many ways to communicate with your patients. It's not even funny. What's another one? I've had pictures, pointing to pictures has helped. It's crazy how you learn how to communicate with your patients. And then with endotracheal tubes, you can swab somebody's mouth. You want to do oral care all the time when you do a vent assessment, but with a trach, you can even give them mouth swabs for their dry mouth most of the time, as long as they're not MPO. You can reduce sedation because most patients, once you get them with a trach, they're not fighting the ventilator as hard. It's going to be more comfortable for them with a trach. So you can take down the sedation, which is also going to decrease what we call ICU delirium. So they can start converting those short-term memories to long-term. So they're not constantly waking up going, where am I? What's going on? Why is there something in my mouth? It's easier to remove secretions. You can suction right from the source, especially when you can hear it. You'll walk into the room and you can hear gurgling noises and be able to suction them out. It decreases work of breathing. This all goes hand in hand. So if they're less anxious, they're more comfortable, there's less sedation, you can coach them to breathe better when they're on the ventilator. And then once they wean off the ventilator, they're going to be so relieved, and you can coach them on taking their own big, deep breaths so they don't have to go back on the ventilator. And then a shorter wean time. So weaning off the ventilator with an endotracheal tube versus a trach. So it's going to, your patients who have a trach are going to wean off the ventilator, which means we give them trials to breathe on their own with help of the ventilator. So we're giving them pressure. And then eventually we'll take them all the way off the vent to see if they can breathe on their own. With the trach, that's going to be easier than with an endotracheal tube. So choosing the right trach for the right patient is going to depend on the patient's age, their height, their weight, and their airway anatomy. So what different anatomical features might affect what trach we choose?
Someone's like obese or not?
Yep,
Like their neck
obese.
size?
So if they have a lot of adipose tissue and it comes out forward anterior, we're going to need a trach that's longer going out from the neck. If we have someone who has a long skinny neck, we're going to want it to go longer.
Like your COPD, late stage, super thin frame.
Mm-hmm. Yep. And that's also going to determine how big the trach's inner diameter is. So how big the tube is itself.
Yeah, kids, they're still growing. It's not fully developed yet.
Mm-hmm. And when we get into the lab and we talk about trachs, we have some little kid trachs and they're so cute. I don't know what it is about the pediatric stuff, but it's so cute. I don't want them to have a trach, but at least they're cute. Okay, so this is the map that we choose or we follow when we talk about taking out the endotracheal tube and putting in a tracheostomy tube. So when we'll start here. So this is the very beginning of mechanical ventilation. So they're going on the vent. So day one, we're going to look at what is going on with the patient. Have they had a trach in the past? Do we anticipate them being on the vent for 21 days or greater? So if you have a patient who maybe has severe facial trauma and the trauma surgeons say and plastic surgeons say this is going to take months and months of recovery and multiple surgeries, we would automatically give them a trach. And the trauma surgeon will probably suggest that. Now, if it's day one, we're getting ready to intubate. We know they need to be on mechanical ventilation and they're there because they have a pneumonia or they are going into respiratory failure because of COPD or some acute issue. And we think, okay, well, maybe a few days to a week, then we're going to intubate. And we're going to keep translaryngeal intubation, which is an endotracheal tube. So every day we're going to look at our patient and we're going to reassess to see if we need to talk about possible tracheotomy. So every day we're going to look, were they able to do a spontaneous breathing trial, which is a wean? How did they do? Do we think that they can get off within the next couple days? Do they have any more surgeries? Are they able to come off sedation? What's going on with the patient? So we'll look every day. And if we think they're going to get off in a couple days, then we'll keep them with the endotracheal tube. If we think that it's going to be 7 to 10 days, keep them with the endotracheal tube. On day 7, 5 to 7, are they still weaning? Are they on heavy medications? Are we having to paralyze them? Has their condition gotten worse or is it getting better? So if the answer to any of these questions makes you wonder, okay, I think they're going to be on for another 5 to 7 days, we're going to get a trach. If you think it's probable after that 7 to 10 days that they'll come off within a few days, we can keep them intubated. Does that make sense?
With COVID, are we just, because I've only really heard about people being intubated. I haven't heard of people getting trachs. but the recovery time is usually more than 7 to 10 days for all the people who are hospitalized with COVID.
So a majority of people are getting trached. Now, if we think that they are going to pass or that they're going to get off, then they would leave them intubated. If they don't have the resources to trach them, it might take longer because these docs are overworked. There's so many patients. So at that
And they're
point,
still on that ventilator. You're not
Mhm.
saving a ventilator. They're still on it.
Yeah, yeah. So it's the resources and how are they clinically doing. Roman, who I worked with at St. A's, who I don't know if you guys were on his call with us when he talked about having COVID-19, he was trached at day 10. And then he eventually was decannulated, so they took it out, and he's doing well now. But a lot of patients with COVID are getting trached. I'll have to ask if they're traching them earlier because they know they're going to be on the vent longer.
Yeah, now that we know more about the virus and how it's work.
Mm-hmm. And predictability. And some of this may totally go out the window. So this is how we should approach it when we should approach physicians. Hey, what do you think about a tracheostomy? Or physicians might come up to you and say, hey, do you think we should give this patient a trach? Now, when you involve family, that's a whole nother story. So you might have a patient who has adamantly said over and over and over, I'd never want to be trached. I don't want a trach tube. Don't trach me. But if they're sedated, intubated, then their family can overrule their medical decisions, which is very sad. There's only 2 states, I can't remember them off the top of my head, back east, I believe, where family cannot overrule DNRs, DNIs, and legal medical decisions. So that's something to keep in mind that you're going to see while you're out there. So this is the basic picture of a trach. So I talked about the flange here. That's what sits against the neck. And we can add sutures here and here until the stoma is established. And RTs at the majority of hospitals are who is responsible for removing those sutures. What do we want to look for at their suture sites when we do trach care?
Any redness, swelling, signs of infection.
Yep, exactly. Because that infection can go into the stoma and eventually they could become septic. So we have the flange here, and then we have the cannula, which goes into the trachea. And attached to the outer cannula, so this is the outer cannula, you have the 15mm adapter here and here. So the inner cannula goes inside the outer cannula, and this is like an extra layer of protection. So if there is an obstruction or equipment failure in the inner cannula, you still have that established outer cannula here. If we didn't have the inner cannula, or we forget to put the inner cannula back in and we get a mucus plug here and something happens, then it's a patient safety issue because this is their only airway. This is how they're breathing. If it gets obstructed, then that can lead to respiratory arrest. So that's why you always want to have the hollow inner cannula. Now, before we put the inner cannula in, when the trach is first placed, we're going to put in what's called the obturator. And it has a rounded tip. So when it gets placed in here, the obturator, the rounded tip sticks out of the bottom. And as you guide it in, as it touches the trachea, it's going to prevent any further airway damage. When we get our hands on those trachs, you'll feel at the bottom of the opening of the trach, it's pretty sharp and can scratch and do airway damage if it's placed without the obturator. So after you place the trach, you want to make sure you keep the obturator and tape it. Every hospital is going to be different. We always had the obturator taped onto our ventilator. If they didn't have a ventilator, the obturator was always taped at the head of the bed on the wall. so that if something happened, they cough really hard, their trach ties, which are like the trach strings, come off and they dislodge their trach, you can safely put it back in without doing damage with that obturator right there. So something you always need to have at the head of the bed with a trach patient is the obturator and an ambu bag. Obturator and bag. Okay. And
Is
then
the stoma the surgical actual opening of the airway, or is it this kind of opening on the trach? You would call that the stoma.
the stoma is the actual opening on the airway, on the skin,
Okay.
on the patient. So this is the tracheostomy tube, or just the trach. Good question. So an important part of airway care with the trach is going to be the cuff. So the cuff sits on the inside and is inflated via the pilot balloon and the one-way valve here and the inflation tubing. So we will measure to 20 to 30 centimeters of water pressure for that cuff, and that's going to inflate, which is going to prevent, if it's in the trachea, it's going to prevent air from going around the trach and up to the upper airway. So it basically closes off the trach and forces all the air to stay in the lungs, get inhaled here, air stays in the lungs, comes out via the trach here back to the ventilator. So this totally bypasses the upper airway. Now, as our patients start to get better and heal, we do ventilator weans. We get them totally off the vent and we put them on bland aerosol. We can drop the cuff so that they can breathe both through the trach and their upper airway. Make sure that you're able to label this. So this is the flange here, and this would be the 15 millimeter adapter on either of these. So we have a Jackson trach. So these are more common in the older population. I've seen them more commonly with older men who have COPD, who maybe have like a ton of secretions or are more of an aspiration risk. They just need that extra help getting those secretions out and protecting their own airway. It is a metal trach. It's usually placed by ENT, which is an ears, nose, and throat specialist. It's also called the Silver Hollinger trach, Hollinger. So as you can see, they're cuffless. So if your patient, say, is an older COPD patient and he comes in for an exacerbation and eventually ends up needing a ventilator, you would have to change from the Jackson trach to a trach with a cuff. You would just switch it out and use one that is the same size. So this has the same inner and outer diameter.
So when patients get off the vent, do we change them out to a completely uncuffed one, or just like leave it not blown up?
It's going to vary patient by patient. If it's acute or chronic. So typically what we do is we first start by dropping the cuff, making sure that they can use a speaking valve and that they can breathe comfortably on their own through that trach with a dropped cuff, and that they won't possibly need mechanical ventilation again. And then we do what's called downsizing. So after the physician is comfortable with how they've been doing, we downsize to a smaller size trach. If they do okay with that, the majority of the time we just decannulate them. So we take the entire trach out and cover the stoma so it can heal. If they are going to need another trach or continue to have the trach for secretion reasons, or they can't pass a swallow eval to protect their airway, then we could go cuffless. Good question.
If they have a metal allergy, is there different ones they can use besides these?
If they have a metal allergy, we would just give a plastic one. So it's made of PVC. So we would just stay with the PVC. Good question. This is the obturator for the Jackson trach. and it has an inner cannula as well. So patients will typically have 2 inner cannulas if they're non-disposable, so that they can clean one and let it air dry and put the new one in, and then swap them out later in the second time during the day. Okay, so that's the Jackson trach. So tracheal tubes can cause airway trauma as well as endotracheal tubes. So first we're going to talk about the endotracheal tubes. So these happen with endotracheal tubes. I'll write it down. So these are endotracheal tubes. So laryngeal lesions are happening because that tube is going through the vocal cords and through the glottis. So you can see glottic edema. So if we extubate someone, what's something we can hear with glottic edema?
Strider.
Stridor, good. So then we could give what? What could we put on there?
Racemic epi.
Racemic epi. What else?
Maybe just some cool mist.
Cool mist, perfect. Racemic epi and cool mist. And then have an emergency airway kit ready just in case it doesn't work. Vocal cord inflammation and vocal cord polyps or granulomas. So growths that have happened on the vocal cords because of that continuous friction. Okay, so with glottic edema, we can have this up to 24 hours after extubation. So you'll learn in critical care techniques, we do what's called a leak test, where we listen with our stethoscope to their glottis and we drop the cuff just a little bit to make sure there's air flowing around it. But we could have a normal leak test and we extubate them and they're good, but up to 24 hours later, they could still develop that edema. They could still have that inflammation.
Are these patients you're going to pre-treat with like cool mist as soon as they're extubated, or just play it by ear?
It's going to depend on your hospital. For cool mist wise, we typically don't pre-treat with that. You may, if you don't hear a very good cuff leak, you might tell the physician, hey, I'm going to need some cool mist and I don't think it's safe to extubate. I think we need to get steroids on board. So there are studies being done to see if pre-treating with steroids 24 hours before extubation helps reduce need for reintubation due to subglottic edema. So the primary symptoms of glottic edema are stridor and hoarseness. Stridor and hoarseness. Hoarseness can occur and does occur in most patients after they are extubated because they haven't been using their vocal cords. They're pretty dry, but it usually resolves itself. Okay, so less common injuries because of an endotracheal tube is vocal cord paralysis and stenosis. And if that is the case, this may be an indication for a chronic trach. So these are what we want to prevent by recommending a trach early in their course.
Do you know what causes that paralysis? My uncle had heart surgery and came out with some paralysis in his vocal cords that never really like fully healed. Did they just like clip a nerve on the way out or going in?
I don't know. That's something I'm going to have to look into. Because I know it's more common if they're intubated longer. So it might just be atrophy as well. So just not using them. Okay, so this is what we want to prevent and why we don't want our patients to be intubated for long periods of time. So this is what can happen with trachs. So know what is caused by an endotracheal tube and what is caused by a tracheostomy tube. So granulomas in the trachea, tracheal malacia, which is softening of the tracheal rings, tracheal stenosis, which is the opposite, which would be the narrowing and scarring of the trachea. A tracheoesophageal fistula. So that would be a hole that is created from the trach rubbing on the trachea between the trach and the esophagus. What may be some signs and symptoms if there is air that is going into the esophagus?
Distended abdomen.
Yeah, bloat.
Distended belly. What does our stomach contain?
Reflux. Acid.
Reflux. Yep.
Yes.
Yeah. So if you have someone who has a trach place, they've developed a esophageal tracheal fistula, and all of a sudden they have these pneumonia-like symptoms and their chest x-rays come back and they're starting to look funny and you start seeing air in the belly, you may have a tracheoesophageal fistula because of that reflux. And then the tracheoinnominate artery fistula, and we will look at a little diagram of this, is when there is a fistula between the trachea and the innominate artery, which is right by the trachea. It's a major artery coming off the aortic branch. So it can cause death by internal bleeding quickly. So for this, your signs and symptoms would be hemoptysis, dyspnea, and cyanosis. But it is going to happen fast. With a tracheostomy tube, are we going to see laryngeal lesions, stenosis, or vocal cord paralysis? No, good. No, because we're not going through the vocal cords or the glottis with a trach. So when we compare the two, endotracheal tubes are more likely to cause damage at the cuff site, whereas the trachs are more common to have damage at the stoma. But it can happen at the cuff and the tip as well. So with the trach, that's why we're constantly looking at the stoma as part of our trach care. So here's some pictures of each. So here we have some granulomas and polyps, but we also have some malacia. So remember that softening of the rings. We have malacia over here as well. So you can see how narrow that lumen is compared to this one. So these are normal, perfect C rings, and here we have malacia. Here we have stenosis. So it's all that airway is damaged and inflamed and thick. For malacia, we can place stents. So we can have tracheal stents that hold that airway open.
Is stenting really all you can do for tracheal malacia?
Yes, and so sometimes you'll have acute malacia that happens after a patient's been trached for a really long time, and then you have to just upgrade their trach size or their airway anatomy changed. So you have to go from a standard trach to an XLT, which is like extra long tall. So it would be longer. So we had a patient who had a stroke and his family wanted to continue care, and he was at an LTAC for a long time and then developed an infection there and came back to our hospital, and we couldn't figure out why he kept peak pressuring and then his volumes weren't being delivered. And so we did a bronch and he ended up having tracheal malacia while he was at the LTAC. And that's another reason why he got an infection, because they couldn't get the secretions out and he wasn't properly being ventilated. And then here you can see how a tracheal esophageal fistula would happen. So the trach here, this is the carina, and then you could slowly see how aspiration of stomach contents would happen. So if you do a flow volume loop on a patient with tracheal stenosis or malacia, so this would be post-hospital, some chronic CFers, asthma patients can develop tracheal malacia. We can find it on a flow volume loop because with malacia, it would have variable patterns. Their loop would have that variable pattern and present as an obstruction, because you can see as they start to exhale, their airway starts to collapse and would start to obstruct. With stenosis, their airway isn't changing at all. So it would be fixed, and it often looks like a ball. So it would be round. So their airway is not going to change based on inhalation or exhalation. So think of this guy is going to be obstructed. Ooh, sorry, that's not very good. Obstructed, and then with stenosis, it's going to be look more like that. So you have inspiration, expiration, sorry, backwards, expiration, inspiration. So you could see where if our patients develop tracheal malacia and they already have an obstructed disease, it might throw everything off. Okay, some symptoms for all of these. Difficulty clearing secretions. On expiration, we try to do that airway clearance therapy and get out those secretions, and then the trachea just shuts because of the malacia. It's going to prevent the secretions from coming out. And with stenosis, there's not a large lumen to get those secretions up and out. Dyspnea and stridor, because you know no other disease process has any of those symptoms.
Everyone shares at least like 2 symptoms so far. Sweet.
So it's really a huge, huge part of our job. We're like detectives, and you'll develop what questions you need to ask. And then having an answer to a question will lead you to another question. So as you follow preceptors, when you hear them talking to their patients, listen to what kind of questions they're asking. Listen to what kind of questions nurses are asking. Talk with your nurses about the patient's history, talk with your physicians, because working as a team is going to help you guys all come to the right answer. Because I guarantee you, especially working in the ED, doctors and nurses are going to turn to you and be like, what do you think? What do you think is going on? It's going to happen. Okay, so this is where the trach sits. So you have the aortic arch here, and you can see that inanimate artery comes right up off the aortic arch. So if we have a trach, I lost my little laser pointer thing. Oh, my mouse died. So if you have a trach rub against an inanimate artery, it's eventually going to poke a hole in it, rub a hole into it, and all that blood pressure is coming out of the aortic arch. That is where the highest pressure is in the body. So you are going to bleed, your patient's going to bleed out quickly. Often the only sign that there is would be, you can see the trach tube itself pulsating a little bit. So this is why it is imperative that we are checking cuff pressures and they're the right pressure. We're going to help prevent this injury. It's very uncommon, so it's 0.1 to 1% of patients after having a trach placed will suffer from this. So very small chance, but it can still happen. It is fatal if it's not treated immediately because our patients are going to go into hypovolemic shock and lose all their blood. And only 25% of patients who develop this survive. If you see that trach pulsating, that trach tube, and you suspect this, maybe you're getting lots of blood in their secretions, and they are cyanotic, and you see that pulsating because there's a slow leak, that would be a time that would be okay to overinflate that cuff, because that cuff is going to add pressure to that artery to help it clot, and then hopefully you can get them to the OR in time to fix it. Okay. So let's take a quick break so I can fix my mouse, and we will come back at 1:35. Awesome. Okay, so let's finish this up. It's working again. Okay, so you can see how that could be very, very bad very quickly. There we go. So we went to the best treatment is prevention when it comes to injuries and trauma to the trach and to the trach itself, the trachea and the stomacite. So sedation. When you hear sedation, what do you think? What do you think of when I say sedated, the patient's sedated?
Put to sleep.
put to sleep. So completely out. So you'll hear, I always say they're snowed, but sedation can be even as mild as an Ativan. So just a little, something to take the edge off. So sedation doesn't mean the patient has to be completely snowed and out of it and not know what's going on. Minimal tube movement. So that would be, we learned about the T-piece. So making sure the patient is not moving around if they're on a T-piece wing, or prefer the T-piece for humidity. That's why it's important if you have, especially with a difficult airway or a fresh trach, and you feel like it's causing too much movement to do trach care, getting an extra set of hands to help you hold the trach while you do trach care. A swivel adapter, which we will play with in the lab if I can find it. But basically it goes on the end of the trach and it attaches to the vent circuit, and it just gives it extra room for the vent circuit to be moved without having to yank on the trach tube itself. Making sure the correct airway is in place, so the correct size. If the stoma, over time, if it's a chronic trach and it's gotten stretched, the skin stretched out, we would want to make sure we have a bigger trach, or if it's healed and we have too big of a trach tube in, we could downsize it and let it heal. Cuff pressure, so know your cuff pressure. Know it for my class, and this is also going to be on the boards. And know it for real life. You're going to see all different kinds of RTs out there who have different thought processes and who practice differently, or lack of practice. So I personally, and a lot of people I know, check cuff pressure every vent assessment, every tracheostomy care check, every 4 hours. When I'm going to see the patient, that's just part of my routine, is checking cuff pressure if it's inflated. Cuff management, you're also looking, so if you have a patient on the floors who has trach care, you always want to check the cuff so you can chart if it's up and inflated or if it's down and deflated. Because if it's up and inflated, that is going to prompt you to chart the cuff pressure. Our hospital policy protocol for respiratory for cuff pressure was to check it Q shift, so once every 12 hours. But that made no sense to me, because how am I going to check if there's a cuff leak? How am I going to check that the cuff is intact? So I wasn't doing anything wrong by checking it every 4 hours, but it wasn't mandatory. So know your hospital's policies and protocols, and you'll develop your own system.
Is that cuff pressure universal across different types of cuffs for like pediatrics versus adults, or the big, like, extra long and tall one?
So that's a great question. So this is just the basic. So with pediatrics,
Okay.
the smaller the tube, it's not going to have a cuff. So like little endotracheal tubes don't have cuffs because kiddos don't need it. This is going to be in adults or older children who have cuffed tubes. And then in the next slide, we're going to talk about a different kind of cuff. So we'll get there. Good question. Because we have cuff design, and it can be foam or water. And that is going to look like this. So this is a foam cuff. We don't have one of these at Pima because they're super expensive. Justin and I were working on getting one, and then we had COVID hit. So when we get back to campus, hopefully we have a foam cuff. A lot of hospitals don't necessarily keep this in stock in the respiratory department either, because it's so expensive, and all equipment expires. So part of like equipment tech jobs or leads, everyone's going to have a different role who gets this role, but checking for expired equipment. So airways, endotracheal tubes expire, masks expire, intubation kits expire. So if you buy a lot of these and have them stocked all the time, even if you're not using them, you risk losing department money because they expire. But what's really cool with the foam cuff is you open this little red piece here up. You can see where that sticks in there. And then through the inflation tube, the foam cuff is going to fill up until atmospheric pressure is equal from the end to the cuff. So it's going to fill up until just right. So we're not having to measure pressure on this. So this is more common in long-term patients and maybe patients who have tracheal malacia or stenosis, because this is going to be more gentle on their airway. This would be also something that we would use in a hyperbaric chamber, because pressure isn't going to decrease the size of that cuff. Because if we're diving down with the hyperbaric oxygen chamber for gangrene or some sort of diabetic wound to help heal, the deeper atmospheres we dive, the smaller that cuff is going to get because pressure is increasing.
Hey, Stacy, so it's like a foam piece that expands within like a plastic cell?
Yeah, so it has like and then when it's deflated, so when you close this little piece here, it holds tighter to the tracheostomy tube. So insertion is going to be better because it's not big and bulky like those other cuffs. It seals tighter to the tube.
Yeah, some of those deflated cuffs are just big, empty bean bags. Seems
Yeah,
like
it was
what
hard
they-
to see. Yeah, no, it's just kind of hard to see on a picture what it looks like. And then you think of foam, it's almost like a sponge in there. It's going to get gunk. So that's, I'm trying to find a picture. Okay, gotcha.
Yeah,
I just
and
can't get over how they spelled foam.
I know, right? I think they had to do it because that's part of the brand name, is Bavona Foam, F-O-M-E.
Thanks, Bavona.
Yeah, just make it easier, right? So the cuff with these and with the saline cuffs, it goes up a little bit higher to help incorporate all of that area. With the saline cuff, and we'll play with those a little bit in the lab, you want to use isotonic saline, and you will use 10 cc's of saline. So when you check to see if it's inflated, you'll pull just a little bit out of the cuff because you're not going to cause a huge leak, and then make sure that it's all the way inflated. And why would we use isotonic instead of sterile water or hypertonic saline?
In case it bursts.
Yep, if it bursts, then the lungs can reabsorb that saline and we'll just change out their trach. So trach care equipment. So be able to list this and not just say a trach care kit, individual items. Because some hospitals will have a trach care kit, which includes all of or most of this, but it's more expensive, whereas a lot of this equipment we can use for multiple tasks. Nursing uses it, so it's cheaper in the long run to get the individual pieces that have multiple uses than just one big kit. So sterile cotton applicators, which are like Q-tips to clean the area. Sterile 4x4-inch gauze pads, trach ties or holder, a sterile brush or cotton pipe cleaners if we have to clean the inner cannula. Now, if they have a disposable inner cannula, you would add that to this list. So 99% of hospitals are going to have disposable inner cannulas, so you're not going to have to clean them inner cannula with hydrogen peroxide or sterile water. Sterile gloves for you when you go to suction, sterile water to clean the site, hydrogen peroxide, which is, it depends on hospital policy and protocol, because hydrogen peroxide, if you're cleaning the stoma site with that, you can promote skin alteration and death at a cellular level. Scissors, if you need to cut any of the gauze pads, sometimes it's just easier to cut off little trach ties. Oxygen, always pre-oxygenate your patient. A spare trach. So in the room, we've already talked about the bag being at the head of the bed and the obturator. You always want to have a spare trach in the room, just in case something happens. So if they dislodge their trach and it falls on the floor, you don't want to put that back in their stoma. Grab the new trach. So you'd have a spare trach the same
5 second
size.
rule.
Second rule, right? 5 second rule. A spare trach the same size and one smaller. A syringe, because that's going to inflate your cuff. And then a cuff manometer. So we will go over the basic steps. Don't worry about having to answer these questions on a test. I just want you to have them in your head. And then when we get into the lab, I will go over step by step and physically show you how to do it so that you can practice it. So obviously we assemble and check all equipment before we get started. So making sure suction is working, making sure your ambu bag is attached just in case, and that you have a flow meter in the room. You can pre-oxygenate your patient, get everything all set up and pretty, and you'll figure out what setup works best for you. Everyone's going to be a little bit different. Always explain what you're doing to the patient. A lot of times, if it's not their first time doing trach care, or they've been off the vent for a while, they're going to know what you're going to do. Even if they're snowed and they're on the vent, explain, okay, you're going to feel a cold Q-tip because I got to clean your trach up. I got to get all this junk off of you. And suction the patient first, especially if they're not on the vent, because then they're going to cough. So if you clean them all nice and pretty and you change their trach ties and their dressings and then you suction them and then there's a bunch of sputum everywhere, you're going to have to do it again. And if you don't do it again after you make a mess, that's just not very nice of you. So please keep your patient clean. After you suction the patient, you remove the inner cannula and either throw it away if it's disposable or clean the inner cannula. Clean and examine the stoma site. So we're looking for redness, we're looking for pus, swelling, bleeding. Is there dried blood? Is there a bunch of dried secretions? How does it overall look? Then we change the ties in the holder. Make it nice and clean. Our hospital policy was to date and initial the trach ties so that it proved, hey, I did change the ties, even though I came back 4 hours later and they were bloody and nasty and gross, and I had to do it again. And then the next shift can see when they go to do it, oh, she did change the trach ties. For some reason, this guy has a ton of secretions, but I'm going to change them now. And the very last thing you do is replace the inner cannula that has been cleaned or a new disposable, and then put that gauze underneath the flange. So we will go over this step by step when we're in the lab. And you guys, I will watch you guys all practice it. We have 2 new trach dummies that you get to practice on. So they have fresh, clean trachs, so you can practice trach care before you get out there. So you'll want to reassess the patient. So when you are doing all of this, you're going to want to pull the monitor to make sure that you can check their oxygenation status, especially while you are suctioning. If it dips down a little bit, you just put the trach mask back over their trach, let them catch their breath, get them back up to where they need to be, and then you can continue. Okay. Make sure I got all my notes. So remember, self-inflating resuscitation bag, 1 trach the same size, 1 size smaller in the room. Obturator at the head of the bed. 95% of the time, you're never going to have to worry about that. Trach care, you're in, you're out. Patient feels better. The family comes into a clean family member. Everything goes good. But it's better to have it and not need it than to go, oh crap, the patient lost his trach and I don't have a bag. And then you're hitting the rapid response button or the code button. So better safe than sorry. So airway emergencies, be able to troubleshoot these. Tube obstruction. So this can happen by the cuff blowing or herniating around the end of the tracheostomy tube. So how you can figure out if it's a cuff herniation is you try to pass a suction catheter. So you pass the suction catheter, it doesn't go through. It could be a herniated cuff, or it could be mucus plugging. Or if the trach is against the airway wall, the tracheal wall. So obstruction can be the cuff, mucus plugging, or against the tracheal wall. So if you believe it's mucus plugging, if you have a patient who has tons of copious thick secretions, you can put a little, we call them pinkies. They're like a nebulizer ampule of saline that's like that big, and instill it down the trach. And sometimes that'll break it up enough to pass a suction catheter. So you can suction out that secretions. If you have a patient on the vent who has a deflated cuff and it's herniated around the end of the trach, you're going to lose your volumes, your airway volumes, and you can't pass the suction catheter. Okay, so as you know, I think by now I like to tell stories from my past experiences. So if you have an airway emergency or you just feel like something isn't right, don't leave it for the next person, even if it's the end of shift change and you're giving a report. We had a patient who was in the cardiac ICU and I was getting a report and I kept hearing the vent beeping and alarming, but it wasn't a higher alert alarm. It was just kind of the, hey, come in here, you need to check me alarms. I asked the previous RT, what's going on with that guy? He said, oh, he's been on spontaneous breathing all day. So pressure support, which is basically, you guys haven't had mechanical ventilation yet. So it's basically, he's breathing on his own with a little tiny bit of help from the vent. He just can't take really big breaths. But something wasn't right, but he didn't take care of it. Well, it turns out I told him to leave. I would get the rest of the report from the chart. I called the doctor and she came over and she said, do you want to bronch him? I said, absolutely. We bronched him. His cuff was blown and covering the end of his trach. This had been going on since like 3 o'clock in the afternoon. Now, sometimes the cuff would move over a little bit so he could pass the suction catheter down, but there was still an issue because the cuff was blown. So if something doesn't feel right, an event keeps alarming, or you will develop these respiratory spidey senses that something's not right, don't get burnt out and say, I'll just leave it for the next person. They seem okay. Okay, that was my soapbox moment. Okay, so disposable cannulas help against mucus plugging. Okay, cuff leaks are another big airway issue. Primarily, it's going to be a problem with your ventilated patients, right? Because that cuff is inflated, so it prevents any of the gas that's being delivered to the patient from going to the upper airway. So it keeps it in the lung and then back out of the trach. So your vent will alarm. It'll say tidal volume not delivered, pressure low. It'll have plenty of alarms that'll tell you, hey, this person's not getting the tidal volume that they need. So you will look at the vent. It could be the cuff or the pilot balloon. So if that one-way valve in the pilot balloon isn't working and you have a slow leak, that can help deflate the cuff. A quick tip for that, they have little red caps or blue cap. It depends on your hospital, but there's little caps that they put in the end of IVs to help prevent infection. Those fit perfectly over trach balloons. So if you're trying to troubleshoot and see if it's at the cuff or at the pilot balloon, you can inflate the cuff to where it needs to be and put one of those caps on. And if you come back later and the cuff pressure stayed the same, you know you have a slow leak from the pilot balloon, and just to leave on that cap. Problem solved. They also have pilot balloon repair kits. So it happens, patients move around. Lots of practitioners are with the patient. If that pilot balloon is torn off or the inflation line is punctured or ripped, you can just repair it with this repair kit. Accidental decannulation is our third. So here's our big three. You're going to need to know this: tube obstruction, cuff leaks, and then decannulation. Those are the three big ones. And the bullet points underneath are what causes them or how to react to them. So with accidental decannulation, stay calm. You're going to think better if you're calm. Stay calm. It happens. Always, always remember that you can cover their stoma and use a mask with their ambu bag and bag them through their upper airway. There's going to be plenty of people to help you. Don't be afraid to use your big RT voices and yell for help. Sometimes it's needed. And that's why you always have yourself prepared. Good practice when you're first starting out, and just to make it part of your routine when you have a trach patient, go into the room, introduce yourself, put eyes on the patient, and then look at the supplies that you have in that room. Make sure you have an ambu bag that has a mask and those 2 trachs and the obturator. If you have those things, you're going to be okay. Make sure you have suction and you're good. Okay, so new trachs that are 4 to 5 days old can close very quickly. So that's why it's imperative that you have the tools that you need in case you need to put in a new trach or grab that obturator and put the trach back in. If you stay calm, then your nurses are more likely to stay calm too. Because usually it's the nurse calling you going, oh my gosh, room 405 lost their trach and I don't know what to do. If you're freaking out, then they're going to freak out even more. And then the patient's going to freak out. So stay calm. You got this. Okay, make sure I have everything. Okay, so suctioning. So the definition of suctioning is the method of mechanically removing secretion from the airways. Mechanically removing secretion from the airways. This is an invasive procedure, which is why we talked about with airway clearance therapy, we want to try directed cough first, because that's not invasive. It requires negative pressure. So we are going to use a vacuum hookup, which is going to be on the wall next to the air and the oxygen. And we want to use aseptic technique, which is clean. So when we suction trachs and tracheostomies, we want it to be a sterile technique. We want to work on our sterile glove technique. When we do NT suctioning, it's going to be a clean technique. We'll talk about each of those procedures. So where to suction? So with the oropharynx, this is that Yankauer or rigid tonsillier I was talking about. This just connects to our suction tubing and just goes into the mouth and the back of the throat. So if you're doing airway clearance with someone and they have a lot of secretions, instead of using a cup all the time, you can use the Yankauer. You're going to hear it called Yankauer, Yonkauer, Yonker. It just depends who you're talking to, but it's all the same thing. If it gets gross and dirty and crusty and full of secretions, please change it. It's gross. and it can cause infections. Trachea and bronchi. So if we're doing invasive suctioning, we're going to use a flexible suction catheter like this guy here. We can either go through the nose and nasal tracheal suction, or we can go through the tracheostomy tube or through an endotracheal tube. With an endotracheal tube or a trach tube, we can do open suction or closed suction. So open suction uses this. I don't have a picture of the other guy. Uses this one. So if we're using this with a trach or an endotracheal tube that's on a vent, we would have to take off the circuit, go down in suction, and then put them back on the vent. If we close suction, and I apologize, I don't have a picture of that right now. I'll get it in Blackboard. We use what's called a Ballard catheter, and it's an enclosed catheter that's attached within the ventilator circuit. So we don't have to break the vent circuit. So no open suctioning, we have to detach from the vent. Closed suctioning, we do not detach from the vent. And then trachs that are not on the vent is always open suctioning. So for NT suctioning, they may need to maintain a patent airway. We may need to remove secretions, blood, vomit, or a foreign body. If they have an inadequate cough and we have to get it out because they're aspirating it, these are all indications. And then always review your clinical practice guidelines. Until you're comfortable with NT suctioning or you don't do it a lot, make sure that you look at your clinical practice guidelines. These are great resources for indications, contraindications, and how to perform the procedure. So NT suction is going to happen for patients without an artificial airway. Why don't we do tracheal suctioning through the mouth without an artificial airway?
Cause more harm going through that glottis, going through that area.
Gag
Well,
reflex.
Gag reflex. Gag reflex. We don't want them to throw up. Some might gag a little bit when you go through the nose, but it's not going to be like the mouth. So relative contraindications. So this is going to be risk versus benefit. So nasal bleeding, acute head, facial, or neck injury. If we are trying to intubate them and they have a lot of blood in their airway and we need an NT suction so we can see what we're doing, we're going to do that first, even though they have a facial injury. Tracheal surgery, a coagulopathy or a bleeding disorder. So this would be something that it's imperative that you look at your patient's chart to see their past medical history before you just go in and NT suction someone. Look at what kind of drugs they're on so you can be prepared if you are putting them at a higher risk for bleeding. If they have an upper respiratory infection, so if they have a sinus infection, because we're going through the nasal passage, we're risking taking all of that bacteria, virus, all those microbes that's in their nasal passage and putting it in their lungs. But sometimes we have to get into their lungs, and even if it puts them at higher risk. An MI, who knows what an MI is?
Myocardial infarction.
Yep, myocardial infarction, also known as a heart attack. We do risk having our patients vagal down when we NT suction. It has not happened to me. It has happened to a friend of mine, and their blood pressure tanked, and They went into cardiac arrest, but they got them back after 1 round of CPR. It does happen. It's very, very rare. Just know it's a possibility. So that's why it's important to always monitor your patients. And then it can cause laryngospasm. Acute, absolute contraindications. So know these. Absolute contraindication, epiglottitis. So way back in microbiology, that bacteria, that gram-negative bacteria that causes epiglottitis, causes the epiglottis to swell. If we NT suction them, we're going to cause even more inflammation, and we risk losing that airway because it's just so swollen. So never, 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 never NT suction epiglottitis or croup. You'll go over that in pediatrics as well. So preparing for NT suctioning. So you're going to assemble and check all equipment before you start. Make sure suction's working, everything's good to go. So first, suction pressure. You want to use the lowest pressure as possible that's effective in getting secretions out. So you may have a low pressure that's working, but if you have to keep going down and making passes, then you might want to turn the pressure up a little bit. So this is what the MBRC recommends for each of these patient populations. So know these because this is going to be on your boards as well. Negative 100 millimeters of mercury to negative 120 millimeters of mercury for adults. You're going to see practitioners, both nurses and RTs, just crank it all the way up. It doesn't mean they're bad RTs or bad RNs. It's what they've been taught. Sometimes it's just what's left on the vacuum. I'm having a brain fart today. It's what's left from the previous practitioner. It is going to be more imperative with kids and infants that you set the right pressure for suction because they're not as developed and resilient as adults are when it comes to suctioning. So negative 80 to negative 100 millimeters of mercury for children and negative 60 to negative 80 for infants. It's important to know, never, never, never preset scheduling for suctioning. So suctioning can cause atelectasis, hypoxemia. We can do further airway damage because think we're just adding that negative pressure. We're sucking everything out of the lungs. So if we continue to do this, a preset schedule, so you would never see a doctor say suction Q2. You can say have orders or policies and protocols that say check for suctioning Q4. So like our trach patients that we would see, they would say suction Q4 per hospital protocol. So we knew basically we're going in, we're going to assess the patient and listen to breath sounds. What breath sounds might indicate the patient needs to be suctioned?
Crackles.
Crackles, yep. You might hear gurgling when you walk into the room. Bronchi, they may tell you if they're chronic or if they've had the trach a while that they feel like they need to be suctioned. You may see secretions coming out of the end of the trach, so then you're going to suction. But if you go in, it's the middle of the night, you listen to them, they sound clear, they're sleeping comfortably, their oxygen is good, their SpO2 is good, everything looks pretty normal. You can chart patient on this amount of SpO2, breath sounds were this, patient sleeping comfortably, suction not suggested at this time or not needed at this time. So you don't want to preset suction. You just want to make sure you're checking on your patients, both trach patients, patients who have had previous NT suctioning. You're not going to order it for a set time limit, Q4, QID. It's going to be either trach checks or PRN. So NT suction as needed. Any questions about the scheduling of suctioning? because a question will come up about that pretty soon. So equipment we need for NT suctioning, we want to make sure we have the suction set up. Suction catheter, sterile gloves. Remember, this is a clean technique, so it's not a sterile technique. It's clean because we're going to go through the nasal passage. So there's no way to keep the trachea sterile after we pass through the nasal passages. Standard PPE, so you want to make sure you're wearing gloves. If they're on precautions, you want to put on the contact gown or mask as needed. I always wear eye protection in the hospital, especially doing things that involve suctioning or aerosol particles, because you don't want to get that in your eye. A sterile basin, so if you have to collect a sputum sample, you can put it in there. Sterile water, you put it in a little cup if you need to. If you get a mucus plug out or something gets stuck in the catheter, then you can just suck up through the water and clear it into the tubing. Sterile saline, if you have to get a little bit in their nares. Oxygen, we always want to make sure we pre-oxygenate. So if they're not already on oxygen, you can bring in a simple mask, an oxy mask, a nasal cannula, whatever is going to work for them. You might need an NPA, which is a nasopharyngeal airway. And it just simply, we'll practice placing these in the lab. It simply just goes in the nair through the nasal passageway for frequent suctioning, and then lubricating jelly. So you want to make sure that that catheter slips through easily as possible. So remember, clean technique. So when we are positioning our patient for this procedure, we're going to set them in semi-Fowlers, and that is here, which leans them forward a little bit because it's going to push the tongue forward and open up the back of the oropharynx so that we can insert the catheter. And then as it starts to go back in the oropharynx, they're going to start coughing. You can have them either take a big breath and cough, or just breathe in deeply. They're going to open their glottis and you're going to pass it through very quickly. You'll know when you're in the trachea because they're going to start coughing a lot. Or if they're unable to sit up, maybe they have an altered mental status, we can put them in the sniffing position, so tilting their head back and their nose up to the ceiling, and insert it that way. We can put a pillow behind their head or roll up a towel. So the steps, again, you won't be able, or you won't be asked to recall the steps. So we are just going to go over them now so you can start to get familiar with them. So we'll use aseptic clean technique. It's not sterile. And it's hard to go over here because I'm not doing it in front of you. So you put on a sterile glove, you take that catheter and you wrap it around your sterile hand, and then you know this one is going to be the cleanest hand, and you can grab other equipment with your other hand. Left or right, it doesn't matter. It's going to be whatever most comfortable for you. With your catheter, you're going to wipe it in some of the jelly in the lubricant, and then insert through the nostril, either side. Not one side is better than the other. And then you're going to advance until the patient coughs or you feel resistance. So if the patient has an altered mental status, or is super sleepy because they're on sedation drugs, you'll feel resistance, and that's going to be the carina. So you don't want to jam it down through their airway really fast. You want to go slower so that you're not doing damage to the carina. And once you feel a little resistance, you pull back a couple of centimeters and then you start suctioning. So don't start suctioning until after you pull back, after you feel resistance. If the patient coughs, you can go down a couple more centimeters and then start suctioning if you haven't felt resistance, because you're in the right spot and you know you're in the right spot. So the less times we hit the carina, the better. So you will apply suction intermittently. So let's go back to that picture. So this guy here, oh, you can't see it. There's a little hole on the side of the catheter that you just occlude with your thumb, and that's what's going to provide your suction. So when you cover it, then it's going to suction out. It's going to go, and then you let go, and it's going to release the pressure that way. So you just occlude it, let go, occlude it, let go, all the way out. Where am I? Okay. Never, never, never suction for more than 15 seconds at a time, because then you have a higher risk of atelectasis and hypoxemia. So it's okay to make more than one pass. So if you don't think you got it all that first time at 15 seconds, you will remove it to the uvular level, so the back of the oropharynx. Let the patient recover, give them oxygen, let them catch their breath, and then go down again. And you can do that a couple times until you feel you've got the secretions you need to. Make sure that you clean up after yourself when you're done. Nurses hate it when we leave trash all over the room. That's just not very polite of us. And it doesn't look good if the family comes in and there's suction wrappers all over the place, and cleaning up trach care stuff. Make sure the patient is stable before you leave. So make sure all vitals are stable, that they're not working hard to breathe, that they feel comfortable. Ask them if they need anything, and then let the nurse know. And then document, document, document. So what do we want to chart about their sputum?
The color.
Color, yep. What else?
Tenacious or
Amount, what did you say, Kevin?
tenacious, or if it's more liquid.
Yep, consistency. Is it frothy, pink? Good, all of those. Does it have an odor to it? What bacteria causes a fetid fruit smell?
Pseudomonas A.
Yep, Pseudomonas. Good job. Okay, let me make sure I got all the notes. Yep. We want to be careful that if they've recently eaten, that we are aware of it, because we don't want to cause them to vomit, because then we're really going to be suctioning them. So if at all possible, if they have eaten recently, try to get them to take some big deep breaths and cough. A lot of times nurses will call you and say, hey, the doctor put in an order for PRN suctioning. And a lot of times you can get them to cough it out, especially when you come in with a catheter and say, hey, I have to put this in your nose if you don't cough for me. So a lot of this is patient education. Okay, so some complications. Trauma and pain. I don't want to be suctioned through the nose. It does not sound like very much fun. Infection, we are going through the nasal passage. Coughing, obviously. Laryngeal spasm is very rare. Bronchospasm, coughing might cause it, and just overall shock to the airway might cause bronchospasm. Cardiac and respiratory arrest, like I said, very rare, but can happen, so be aware. So always have a bag in your room, a bag and mask if you're going to NT suction. Atelectasis, we're sucking that gas out of the airways, so we are likely to cause some atelectasis. Increased ICP from stress. Hyper or hypotension. Gagging and vomiting. Mucosal hemorrhage. So if we are very aggressive with our catheter, and we are going to see pictures in a minute, they have a bevel tip, and they're plastic, so they can be pretty sharp. We can do damage if they have very delicate mucosal membranes. We risk that hemorrhage, bloody nose. If we jam into the carina too many times, we're going to cause it to bleed. That being said, if you see a little bit of blood streaking when you're suctioning the sputum out, that's normal. There's something pouring in there that's not supposed to be there, but there should never be loss of frank red blood. We can cause cardiac arrhythmias, bradycardia, hypoxia, and hypoxemia. So we'll talk about the catheters themselves. So it is size is expressed in French. So it'll say French gauge, or you'll hear, I need a 14 French, I need a 12 French. 1 French is 1/3 of a millimeter in diameter. A great rule of thumb is that your catheter should never be greater than half the size of the airway. So when we talk about NT suctioning, we're not as worried about French unless we have this little teeny tiny old lady. We're going to want to try and use the smallest French we can for our patients, just out of comfort. But sometimes we've got to get the big ones out. You don't have to worry about converting. Okay, so we have the whistle tip catheter. This one's the most common that you're going to see for NT suctioning and open trach suctioning. Here you can see it better where we intermittently suction. We occlude the thumb over this hole here, and that causes all the pressure to be sucked through the catheter. We let go, and then that lets air be sucked here instead of through the catheter. So we occlude this to apply suction to the airway. You can see it's a bevel tip, and then there's an eye on the side. Why would we have an eye on the side of a suction catheter? So it will prevent damage to the mucosa. If this end of the whistle tip catheter gets stuck on the trachea or the mucous membrane, then we have extra suction. It's like putting the end of a vacuum hose to your hand, and you can feel that suction. That's what's happening in the trachea. But with this Murphy eye here, then it's going to relieve some of that suction pressure. Does that make sense? Okay. You have a Q-day tip. So this is going to be a tip that's curved at the end. It'll help go into a specific right or left main stem. So this would be someone who needs specific suctioning. It's not as common. You would be more likely to see that with an advanced practitioner, ENT, pulmonologist. But at that point, they would now more likely do a bronch to get those secretions out that they need to. Here's the closed system. So here's our closed systems I talked about for trachs that are on the ventilator and endotracheal tubes. So you can see it's the same type of catheter. It's just enclosed in plastic. It attaches the suction here. And then this guy here on the side attaches to the vent, and you can push the catheter down into the endotracheal tube. And because it's constantly attached to the circuit, we don't have to worry about breaking that circuit. So it decreases ventilator acquired pneumonia, and it's going to be easier on us. You want to make sure that you pull the catheter all the way back so you're not still in the endotracheal tube, because then we decrease the flow to the patient. There are 2 lengths. One is for the endotracheal tube because that tube is longer. It has to go further into the airway. And then we have a shorter one for a tracheostomy, because if we leave the endotracheal tube one on and we have people who just jam that suction catheter down there, we risk airway damage being done. it can go further into the airway and cause more damage. So we want to make sure our trach patients have a trach Ballard. So closed suction catheter or Ballard. Okay, so our last slide. So this is a Lucan's trap. So this attaches to the suction catheter here. Oh, here, sorry. Suction catheter and then suction tubing here. And it goes in between the catheter and the collection container so that when we get the sputum, it's caught in this trap. We take off this lid, put on a standard lid, and take it down to the lab after it's all labeled for sputum collection. Why might we not want to use saline, if at all possible, to get these samples?
Might dilute it.
Sputum.
Yep,
Yeah.
dilute it. So, and it'll affect the consistency of the mucus. So there's nothing worse than you're trying to get a sputum sample. You've tried all shift to get a sputum sample. You finally get one, but then the lab calls you back and says, hey, I can't do anything, it's diluted. And then you have to try again and get a sputum sample for this patient. The only time that this would be acceptable would be if we're doing an RSV test, a nasal wash. And with that, I'm sure Justin teaches about it in pediatrics. We have this little cute mushroom looking tip suction catheter that you put in the kiddo's nostril on one side and you squeeze saline in on the other, and it washes it out to get that sample from their nose. They don't like it. Kids do not like that.
The Lucan's trap, is it limited to what it can be attached to? Closed circuit, open circuit, or anything like that?
It can be attached to either of those. You can attach it to a bronch if you need to get samples from a bronch.
We saw the video of them doing it on a bronch, but that's cool.
It's really cool. And of course, everywhere you can hear Lucan's trap, sputum trap. Our ED called it something really weird. I can't remember, and that's why I can never find it. But yeah, you can use it on all kinds of things. And then this, you can take this lid off and just put a normal lid on that's basic, and try and walk it down to the lab rather than just sending it via tube system. Sometimes things get lost. Any questions for me? Thoughts, concerns?
So what do we need to do for the extra 5 points?
So just for the extra 5 points, just go back and watch that video that was in the beginning of the lecture, and then submit 2 questions that you have about the video. I'll answer you.
But shoot you an email with those.
It's in Blackboard.
It's already in Blackboard. Cool.
Yeah. Yep. All right. Well, everybody have a